this month's speaker, Dr. Andreas Laupacis. Lots of interesting things I think we'll be discussing this afternoon. Let me do a brief intro. You have one in the flyer for the seminar, but I think it's important to highlight a few things. So obviously, where Andreas is currently affiliated is listed here. Came out of a medical training as a general internal medicine specialist. Obviously received his most important training here in HRM. He knew I was going to say that. Which at the time was called the Design, Measurement, and Evaluation Program. So trained here, and we have one of his former supervisors here, David, or supervisory committee members, David Feeding, who's on this committee. So they're getting reacquainted. Andreas has done a whole lot of things. I mean, when I was looking at various bios for today, recognized that one of the broadest kind of terrains of research interests and activities, starting from kind of classic clinical epidemiology, moving into pharmacoeconomics and drug policy. You guys were talking about economic evaluation work. Most interestingly, in the last number of years, I think you would say you've gotten even broader in your interest in broader health services research and health policy, and now moving into the realm of citizen engagement policy and patient involvement in research priority setting. So really interesting set of interests and interesting career path. What you're going to focus on today is obviously on the research priority setting piece, a little bit on healthy debate from my advanced look at the slides. Also wanted to mention, because it's important for students and just thinking about career paths and what they can do, Andreas is not at all just a researcher. He is someone who's contributed and very actively involved in a number of leading roles in the health policy domain in Canada. Formerly past president and CEO of ISIS, which we all know well, but now more significant roles even as board chair of Health Quality Ontario. He's on the board of Cancer Care Ontario. Has been on the Alberta Health Services Board, so also roles outside of Ontario. I think inaugural chair of the Expert Drug Advisory Committee in Canada. So lots of scope, busy guy. We're really pleased to have you here for a few hours today.
Thanks. And a few hours includes the lunch after the talk's only an hour. Really great to be here. I'm back into my old stomping grounds, even though we weren't over in this building at that time. You know, the introduction, for those of you who, I think most of you are in healthcare and health services research, I mean, you know, just the initial sort of comment is, like, we're just incredibly privileged to be working in the area that we are working. Particularly those who are clinicians, actually, we can still kind of continue to see patients, and I sort of morphed my career from general internal medicine. I now do palliative care. I'm starting a 3-week stint on a palliative care service on Monday. And then just have this incredible opportunity to actually, my career actually, I've very much influenced my career by Dave Sackett, and one of the things Dave has done throughout his career actually is kind of every few, well, significant number of years, but actually changed his focus, right? I mean, he started as a compliance guy, and then he went into something else, and I've sort of actually changed I haven't gone from sort of health services research into abstract art or anything, but you know, you do have the chance to change significantly, and it's just a lot of fun. And so my most recent, I'm probably, since I'm turning 61 in about 10 days, my probably last significant change is sort of moving into this area of patient engagement, both in health services research and actually just health services delivery in general. So with that intro, Julia sent me an email last week and just asked if I would sort of touch on healthy debate, so I'm going to do that at the end. And I hope I'll leave about 20 minutes or so for discussion. And actually, if anybody wants to interrupt me as we go, that's fine. Like, I'm not wedded to these slides and happy not to go through them all. So I'm going to start the discussion. So I am going to focus on some work that actually has been led by folks in the UK through an organization called the James Lind Alliance that I've sort of shamelessly borrowed. But some of the work that I've done recently, engaging and involving patients in helping set research priorities. I was presenting some of this at Medical Grand Rounds at St. Michael's about 2.5 years ago. And actually, Lisa Hicks, who's a hematologist at our place, came up to me afterwards and said, "Hey, do you know about this guy, Michael Cass?" And I said, "No, I've never even heard about him." still have never met him, but I've corresponded with him briefly by email. And Michael has multiple myeloma, which is actually for most people, he's a pretty healthy looking guy here, but for many people, it is a very serious disease. It's a cancer of the bone marrow. And Lisa brought him to my attention because he and a number of patients with multiple myeloma were very instrumental in convincing a number of hematologists to do a randomized trial that they would never have done without this guy and others pushing. And the story briefly was, I'm not sure how many years ago this was, probably about 10 years ago, people with multiple myeloma would get chemotherapeutic agent, plus they also got a large dose of Decadron, a high dose of steroids. And that was standard treatment. And when Michael and patients talked to each other, they hated the friggin' steroid. It gave them lots of side effects. It made them feel unwell. And frankly, actually, a number of them actually weren't taking the drug like prescribed, and in fact, they didn't sort of tell their physicians. And their question really was, in the era of like stronger chemotherapeutic agents than we had before, maybe we could get away with a lower dose of dexamethasone. And to make a long story short, they actually convinced the hematologist to design a study, so conventional chemotherapy plus conventional high-dose dexamethasone versus conventional chemotherapy and low-dose dexamethasone. The trial, I'm actually not sure what the sample size was, but basically it was designed as a non-inferiority trial. It was thought that they were hoping that the low-dose dexamethasone would be about equally effective to the high dose, but there'd be fewer side effects. And actually, the Data Safety Monitoring Committee recommended stopping the trial early because the one-year survival on the low-dose dexamethasone group was 96%, and it was 87% in the standard dose. So, a 9% improvement in all-cause for survival. That's pretty hard, like number needed to treat, which is another thing I developed while I was here at Mac, of sort of 11. It's a pretty damn effective treatment, right? And I actually emailed the guy, Dr. Raj Kumar, who was the oncologist at the Mayo, to sort of say, like, is this story really true? And he basically emailed me back and said, absolutely. He says, this trial found that low-dose dex saved lives. It's now the standard therapy for almost all new myeloma regimens. The idea for the trial came from patients through Michael Katz, a myeloma patient, support group leader, and patient rep, who posed a simple question: in the era of new drugs, do we still need the toxicities of high-dose dex? And argued that only the publicly funded groups rather than industry can answer these types of questions, blah, blah, blah. Mike was an author on the paper. I think he's the third author in the paper in Lancet Oncology. The role of patient input through him played in this trial has been highlighted in meetings and lay articles, but not in the medical literature as far as I know, which I think is kind of interesting, right? Because I did do kind of a PubMed search to look for this and couldn't find anything about the guy. So, and then actually, his final comment from Raj Kumar was, let me know if further questions. I agree with you that we're not listening to the patients enough. So, I mean, you choose your anecdotes for reasons. This is a pretty, dramatic anecdote, but I use it because A, it's true. B, a lot of people sort of think, well, if you just do what the patients suggest around research, they'll get you to research all the soft and fuzzy stuff, like, are they fatigued, are they blah blah, and we won't focus on things like mortality. Well, first of all, I think the soft and fuzzy stuff is like super important. Most of the stuff I do doesn't extend, well, especially in palliative care, but even in general medicine, doesn't extend lives. But I think it also illustrates that, patients are just as interested as anybody else in treatments that might actually kind of extend their life. I'm not going to go through this in great detail, but I think, it is kind of weird if you think about it. In health research, we generally don't actually ask patients, what do you think we should be researching? If you think about it, I think it's incredibly arrogant of us, actually. And they live with the disease. We're asking them to, I tried to park here at friggin' Mac today, and it took me like half an hour. And so, you're getting patients to come in and park and have their blood work taken and stuff, yet we don't sort of say, you give them even any input into kind of what kind of research we're doing. So the issue around justice and fairness, I think the Michael story illustrates that they will either sometimes or often identify research priorities that are different from researchers, and if they're the same, they sort of give the imprint of sort of approval on that. There's actually increasing work done on, they think about outcome measures differently than us. So in the area of rheumatoid arthritis, the rheumatologists were focusing almost entirely on pain for many years until they actually talked to patients and found out that fatigue was a super important thing for them as well. This is a bit part of a bigger talk, but I think the reason to involve patients in research is not just in research priority setting, which is what I'm talking about today, but for a whole, in the design of the study and the conduct of the study and the dissemination of the results, et cetera. And I think, I'm going to talk very briefly on one slide about sort of evaluating this. We don't have great evidence on this, but, the general sense, I think, is that they will improve the quality of the research. And actually, in this day and age of, I think maybe the converse is true. I think if you don't involve patients in research priority setting, they're probably less likely to want to donate. And I think, the MS Society, my understanding is, had a marked decrease in donations around the controversy about whether there should be research in this kind of very controversial area of chronic cerebrospinal venous insufficiency. And I think a lot of that was the patients just sort of feeling like, I'm not saying it was right or wrong, but that the MS Society isn't really listening to us in terms of what we think are important issues. So I think for disease-specific, I'm not talking about the CHR, but for disease-specific charities that depend upon donations, I think actually if you're not, increasingly I think if you're not shown to be genuinely listening to what's important to the people that are giving you donations, that's probably not a winning strategy. I'm not going to go through this actually, but just to make the point, like I just said, that I'm talking about patient engagement in research priority setting, but there's a whole, and there's a group in the UK called Involve. If you Google them, Involve NHS, it's got some actually quite nice documents that with case studies of the way you can involve patients in research all the way through. So to move now to the work that I've sort of, with many others, have been doing in the last 2 to 3 years, really inspired by this guy, Ian Chalmers. So Ian has been knighted because of his work in setting up the Cochrane collaboration, but about 10 years ago, he actually sort of said, look, we're not, and actually he was interested in 2 groups that he felt were not actually having input into research priorities. One was the patients, well actually 3, patients, and what they call and what we've been calling carers, so people that may look after and help look after patients who are quite ill, and actually frontline clinicians. So Ian's feeling was that like clinicians like myself who work at a quaternary care teaching center do have some input into research, actually quite a bit of input into research priority setting, but like Doc working in Peterborough or Niagara Falls, who may see actually frankly way more patients than I do, because that's all that Doc does, and whose research priorities might be different than mine, has absolutely no say in setting research priorities. So the JLA's got actually quite a nice, it's not the most attractive website in the world, but it is a website that's chock full of information. So if this turns any of you on, they've got their protocols and just a lot of stuff on here. But basically it's an organization that got a grant from the National Institute of Health Research in the UK, but has been felt to be so successful that it's actually now been incorporated into the National Institute of Health Research. It's actually part of the NIHR in the US, which is sort of their equivalent of the CHR. It don't largely fund clinical stuff and not basic science. But this thing here is it brings patients, carers, and clinicians together to identify and prioritize the top 10 uncertainties. So they tend to use the word treatment or management uncertainties or unanswered questions about the effects of treatments. And actually the example I'm going to give you within dialysis, we deliberately chose the word management because we thought there might be some questions around the diagnosis of various side effects or complications in dialysis that patients might be interested in. So the ones I've been involved in has tended to use management rather than treatment, but whatever. So it's basically, I started the talk by saying I'm going to talk about involving patients in research priority setting, but the JLA is really about bringing patients, their carers, and the clinicians, and clinicians is writ broad, nurses, physios, dietitians, etc., together identify what they think are the top 10 research priorities in a particular area. And the JLA's done about 25 to 30 of these, I think, now. They're all, most of them up on their website, and I think there's around 10 or so sort of still underway. And I'll just really sort of introduce you to the steering committee that actually, so the first one I did was in dialysis. So it was about the research priorities of patients, carers, and clinicians in dialysis, or patients who are just about to start dialysis in the next few months. So that was the kind of the issue. So Sally Crow on the top is actually someone who's worked with Ian for years, who actually has facilitated a number of these JLA exercises since I'd never done one before. So Sally was involved with us. And this basically took us a year from beginning to end. And we had a 1-hour teleconference of this steering committee pretty well every 2 weeks throughout that year to kind of do this. And so Sally was with it. And then Sally flew over for the final workshop to chair the workshop. And then Annette is a woman from Dartmouth, Nova Scotia, whose mother is on dialysis. Michael is a guy from Whitehorse in the Yukon who was about to start dialysis. Brenda and Braden are two nephrologists at the University of Calgary. Claire is a social worker who had been on a number of different dialysis modalities in Calgary. There's me. Aaron was our research coordinator. Howard is a businessman in the Eastern Townships in Quebec. Brenda is a soil scientist in Saskatoon. I've actually forgotten what kind of dialysis she was on, whether it was peritoneal or hemo. And Wim Walsh was at the time sort of the VP research of the Kidney Foundation of Canada. So general principle of anything that JLA does is there have to be about 50% of representation of patients and carers on any committee, anything you do. So if you take Aaron as our sort of support person out, it's 5 and 5 here. You know, generally there's a group that is kind of supporting this, which would be the Kidney Foundation of Canada here. Yeah, so that's and so, you know, very different from, I don't want to sound cynical, but often in Canada, you know, we feel great if we have one patient on a committee of 10 or whatever, right? So this was truly like an equal representation. And to take you through the year, I mean, the way the process, it's not rocket science actually, is by potential partners, they mean like bringing the people that are interested in this question together. And by the way, the Kidney Foundation of Canada didn't come up with any money for this. Braden and Brenda had some leftover CHR funds, and we got a workshop grant from the CHR. But, you know, we got support from the Canadian Society of Nephrology. There's a, you know, Canadian Dialysis Nurses Association, etc. I'm doing one on chronic fatigue syndrome now, and there's like just a profusion of like Lyme disease and you know, groups that you want to make sure that they're aware of this, that they're kind of on board, and that they can actually advertise this to their members so that they will participate. And basically it starts with basically an open call to all carers, patients and clinicians to largely through a website, log on to the website and tell us what your research priorities are, or your treatment uncertainties are. It's obviously worded a little more sort of friendlier than that. And we do it sort of like we teach the medical students to take a good history, is to start with like, tell them what you're asking for and say just broadly, what are they? And then for the dialysis one, we had about 8 sub-questions, like is there anything about your diet, exercise, etc.? Is there anything about the drugs you're on? Is it anything about the modality of treatment you're on, etc.? And we did actually decide, because we thought some elderly people, particularly who were frail on dialysis, might not be wanting to get on a website. In about 4 dialysis centers, we handed around a hard copy of the questionnaire and asked the nurses to sort of help the patients if they wanted to fill it out. But largely this day and age, most of the responses come through the website. And the websites are usually up for about 2.5 months or so. So they've got to be up there for a while. And then the other thing that the JLA does encourage people to do is to look at sort of well-accepted clinical practice guidelines in an area, and basically say if something is a level E or D recommendation, it probably is suggesting that we don't have good evidence for it, and that might be a research uncertainty. So they're kind of thrown into the mix as well. Then in our case, the steering group of 11, or Aaron didn't participate, of 10 of us actually went through a process of, I'll show you how many came through in a sec, of taking the whack load of stuff that you get down into sort of an agreement on what the top 30 are, that are then presented in a one-day workshop, which is sort of the penultimate thing, to come up with the top 10. And so in terms of what happened with dialysis, we got 323 respondents. I was initially very depressed about that. I had this kind of image that we get like 5,000 people that would be so keen on this thing, and I thought, holy, we got crap load of work we went through. Like, you know, the Kidney Foundation of Canada was tweeting it out, I was tweeting it, it was in the Canadian Society of Nephrology newsletter, et cetera, et cetera. I'm not upset about that now at all, because actually at a certain stage you get sort of saturation of things that come in, and actually if we had 1,000, like it would have been, I'm not sure it would have added much, and it would have just been a huge amount of extra work. But actually the people that responded had a lot to say, right? 323 responded, and they suggested 1,820 potential research questions. So that's about, if you do the math, it's about 6.5 per patient. I was just talking to someone else in the Winnipeg airport yesterday who's doing one, and they just looked at theirs and they got 10 per respondent. So people that do respond generally kind of have a lot to say. Now, there were some of them were clearly out of scope, so we clearly said we're not interested in pediatrics. We got some stuff on pediatrics. We clearly said we're management of dialysis. We got some stuff on how do you prevent kidney disease, so those get thrown out. And you know, we can talk about it in the question period, but you got to have a way of taking this massive 1,820 down to 30. And so even before we got the questions, we sort of brainstormed around how would we categorize them. So we had, like, you know, one's on palliative care, one's on medicines, one's on diet, so that you can kind of put them into buckets. There are a few that you get that you actually just don't understand what the respondent's talking about, to be honest. And there are a few that are just pleas for help but aren't research questions. Like one I remember is one guy said, I'm not the man I used to be before I got kidney disease. And clearly there might be a research question there around impotence, but like, don't know what it is. So that would be an example of one at 227. That's just a comment, but you know, not sure what the research question is. Yep.
I was just curious, we did a similar exercise, well not similar, but we were interested in research prior to studying mental health.
Yep.
And did a different process around individuals with lived experience and families.
Yep.
And researchers and clinicians in Ontario to try and get a better sense of what the priorities were for the province.
Yep.
One of the things we found at that point was we also had a bucket of things that actually you had good research about,
Yep.
but people hadn't identified it. So
Yep.
we bucketed that into a need for better KT.
Yep, and in here somewhere is, so one of the things, shoot, I thought there was but one of the clear things is that you need to go through what people have prioritized, and you know, if the question has already been answered with high quality research, then it gets taken out. Now, I'm going to show you a few of the final top 10 of a few of the ones I've been involved in, and some of them are pretty broad research areas. So, and you know, of course there's been decent research in those areas, but then the question to the committee and people at the workshop is, you know, is there still a whack load of work that still could be done in that area? But yeah, I've forgotten in the dialysis one, but there were a couple very specific questions, and the nephrologist said, well, you know, there's a 2,000 patient randomized trial of that exact question, and it was definitive. So we would just take that out. The other thing that we found is that, and I'm going to get to it, is sometimes there were questions around how do we make the health system better? And the question was, is that a research question, or is that something that Eric Hoskins should deal with? And so, but I'll get to that in a sec. But, and that's why, yeah, so to make a long story short, the other thing is that, and when I say there were 1,820, I spent actually literally a whole flight from Heathrow to Toronto once, taking 1/3 of those 1,820 and kind of starting to lump them. And you know, there were just a bunch of questions on itching. So I can't remember the number, but there were about 40 people that either said, and it was somebody would say, I want better treatment for itching, or someone would say, I want better ways of kind of managing it or whatever. And as the steering committee, we together would sort of say, okay, these 33 questions on itching, we think fit into, and then we would make, and try and be as faithful as we could to what came in. The question might be, I want research in better ways of managing itching. So a bunch of them came together. So in the end, there were 115 uncertainties that were only mentioned once, and then 144, and the JLA uses, I'm not sure why, this term indicative questions, and the itching would be an example of an indicative question where you've taken a bunch of questions in the same area and sort of put them in together. So that gave us 259, and then through a process which we did over a couple teleconferences, we sort of individually ranked these 259, and then, obviously some all came to the top and a bunch all went to the bottom, and then we had a process on the phone that allowed us to get to the top 30 to the workshop. And just a quick thing, this is sort of the characteristics of the people that responded to the website. So you see actually, more patients than healthcare professionals, which I think is good. More nurses than physicians, which is also good because actually they spend more time with the patient on dialysis than do the docs. Not that many caregivers, but still not a sort of insignificant number. And we were pleased that there was a mix of people. Although those of you who don't know anything about dialysis, there's different ways you can get dialysis at home, in hospital, peritoneal, hemo, and the research issues of those people might be quite different. So pretty decent mix. So the workshop, which I was sort of super kind of nervous about, to be honest, and I was super nervous about like how are my colleague clinicians going to behave with all of these patients. But actually it was I've done 4 of these now, and every one of them have been great, to be honest. So there were actually this is the biggest one that I've done. There were 34 participants, and then I was actually one of the facilitators, and Sally and someone else came from the UK. And you can see again, 16 patients or carers and sort of 18 clinicians, or I think allied health professional would have included. We had a kinesiologist. And we used a bit the responses to the questions to choose our professionals, so that there were a number of questions that had a kind of psychiatric overtone, issues around depression, but also pain management. So we actually decided we wanted a psychiatrist to be one of the clinicians who was there. And we, again, some practical issues, and we wanted a mix of people on hemodialysis and peritoneal dialysis. People that have hemo actually have to physically be dialyzed in the hospital every 2 days, and trying to arrange that for someone from Vancouver, if they came to Toronto, just was too much of a, we were planning to do that, to be honest. It was just too much of a logistical nightmare. So we had one peritoneal dialysis patient come from Vancouver, but she could dialyze in her hotel room. But we basically made a decision that all hemodialysis patients, they didn't all come from Toronto. We had a couple come from about 60 kilometers away, but came from the GTA just for logistics. So there's the whole crew. Just want to point this fella out, just for, I'm sure he's not watching on video, but to kind of thank him. You can tell he's a fairly frail, not super elderly, but little elderly person on dialysis. He came from outside of the GTA. He actually had to leave at 3 o'clock because I think he really was glad to be there and glad to participate, but he was just exhausted by the end of it. And he was there with his caregiver, who was his son, there. And I point him out, just like, because I am incredibly grateful to this guy for doing what he did. Not that I'm not grateful to everybody else, but also he's the kind of person that we actually probably don't have as much a say into this process as the healthier people with dialysis, and that's, I think, I'm going to get to the limitations. It's just really hard to I think, get to, because people that feel ill just often don't have the time. And we got some quite moving testimonials from caregivers of patients saying, I can't even get my dad to answer this because, frankly, like, he just feels so sick, like this is just not a priority for him. So the way the workshop works is every participant ranks the top 30 before they come, independently, 1 to 3. We meet them and orient them, and the main orientation is, we can almost guarantee you that your top 30 are not going to be your top 10 are not going to be the top 10 when we leave the room together, or at the end of the day. What we're here for is to come up with a top 10, and what you should feel comfortable about at the end of the day is that you've been involved in a process that's been respectful, that's listened to the views of everybody else, and has come to a top 10 that kind of reflects the input of all the people that submitted their input on the website, and reflects the views of the people in this room. So it's just important, and you should, argue for the things that you really feel passionate about, but this isn't about getting your top 10 on the top 10 no matter what. And frankly, it's rarely been a problem. There's 2 clinicians in the 4 that I've done that towards the end I thought were unreasonably aggressively pushing for something, but that's a super minor thing, but I think it's really important to lay that out right at the beginning. And then we were divided into 4 small groups, so groups of about 8, and believe it or not, in a 3-hour period, worked and together kind of put those top 30 into a general order of 1 to 30. And the technique usually is actually start by just going around the room and say, would you tell us what your top 3 were and what your 27, 28, 29 were, and just briefly why, and kind of go around the room. And what you generally find is that a few just kind of percolate to the top, a few percolate to the bottom. You find actually sometimes that someone's top 3 was actually someone else's bottom 3, and that gives you an opportunity to talk about that. And basically you go through a process. At the end of the morning, each of the 4 groups has kind of ranked them in 1 to 30. And the JLA uses, it initially seems kind of hokey, but it really works quite well, that all the top 30 are put into a series of cards, basically paper-sized cards, that can be moved around and spread on a table. And as you're talking about them, kind of spread them physically. And on the back, if you flip it over, you can see how many people on the website suggested this particular question. And we put it into how many caregivers, how many clinicians, and how many patients. And so, this is a carer and a dialysis nurse. This was the small group in the morning that I facilitated. You can see some of the things are kind of coming up towards the top. There's others to the bottom. That's sort of the way the table looked towards the end of the morning. There's another one of the small groups. I sort of love this picture. This is a patient on dialysis. This is her carer, her daughter. This is a gentleman in his 80s on dialysis, his wife, and a vascular access nurse. And so then at noon, actually, basically the rankings of the 4 groups are averaged. And you also look at them, and I did one on kidney cancer about 3 weeks ago, and it was amazing. There was a question about the use of complementary and alternative medicine, and it was in the bottom 3 of 2 of the groups, and it was in the top 3 of one of the other groups. And so then that's an opportunity at the end of lunch to sort of have someone from the group that ranked it highly get up and say why, and someone from the group that ranked it lowly get up and say why. And again, it's not about kind of arguing for or against, but sort of articulating why. But what often happens is that you look at it and many of the things that were in the top 5 or 6 of group 1 were in the top 5 or 6 in group 2, 3, or 4. So you start the afternoon, you walk into the, and then we actually rejig the small groups, so they're not in the same small group in the afternoon. And they walk into the room, and actually the cards are arranged along the table in the order of the average of the morning. And then there's another small group session to sort of move them around, talk, and then because people are in different groups, they'll sort of say, well, geez, we had depression way lower in our group because of this, and then someone who was in the group that had depression high would sort of say, and so basically have a discussion, rank them again, average them again, and then come back together for the final, kind of with the whole large group, sort of saying, this is what it's looking like. We're now actually only really going to concentrate on sort of 7 to 14, because by then people have clearly agreed on the top and the bottom, and then there's a bit of a discussion, and actually the kidney cancer one, actually the group just spontaneously, after a bit of discussion, sort of said, look, we were very comfortable with the process that went on before. We don't want to get into a process of the loudest voice in this large group changes things, and they all actually voted just to keep it exactly the way it came. I've been in another group where they've been just moved around a little bit. And so here's the top 10 from dialysis, and they really are pretty variable. Number 1, what's the best way to enhance communication between professionals and patients to maximize decision making? I won't go into the detail. This has been published, by the way, in a Nephro journal. Different dialysis modalities, what's the evidence for if I take peritoneal versus hemo on my long-term important clinical outcomes? Here's the itching one that I mentioned. best strategy to increase kidney transplantation? What's the psychological and social impact of kidney failure on patients, etc.? What are the best ways to promote heart health in people on dialysis? What's the impact of dietary restrictions, but not on some fancy blood tests, but on important outcomes such as quality of life? I personally didn't like this question, but this is an example where you kind of go with the flow, and sometimes you just kind of, you don't get everything you want. I thought this question was way too broad, but people found a number of these symptoms just came together on dialysis. What's the causes and effective treatments of depression in dialysis patients, and what's the best vascular access? This is a way on hemodialysis of getting access to hemo. So, that's been published. That's been, I sent this to Alain Beldier, the president of the CHR, and various people in nephrology research settings. It's too early to show. Certainly, there's quite a good developing evidence in the UK that the JLA top 10 have impacted upon what's actually being funded. And so, just given time, my reflections on the process, the workshop with the mix of patients, carers, and clinicians just has worked brilliantly actually so far. I mean, you obviously got to choose your patients, carers, and clinicians appropriately. I mean, there are people I'm sure that Julia wouldn't stick on a committee in her department because they don't function well on committees. I mean, that for sure happens to me at the leak I Shing. Like, there's no friggin' way I put them on a committee. If I have obviously, right? I mean, maybe smart as hell, but they kind of dominate or whatever. And it's the same of, but it's the same of patients, clinicians, and carers. You just got to be careful about who you're inviting. I did think the process was respectful. It's clearly not an exact science. Another workshop would, actually probably likely is not true, would almost certainly have come up with a slightly different top 10. By the way, we published in the paper the top 30, so you can, so you can look at 11 and 12 and 13. As I said before, I'm not that fussed about that anymore. It is sometimes hard to sort out if it's submit. So one example would be about 25 people in the survey said it's a big problem for me to travel on hemodialysis. I can't. Actually, one person said it's easier for me to go see the Florida Marlins. This person obviously doesn't live in Toronto. To go see the Florida Marlins play baseball than the Toronto Blue Jays. Because I go to Florida, I just sort of zip my medical record to some clinic down there, and they accept me, and I get dialyzed. I can't friggin' get a dialysis spot in Toronto. So is that a research question, or is that a health policy question? We decided it was a research question. We said, in a publicly funded healthcare system with finite resources, can you figure out a way of having some flex beds to accommodate people on dialysis who would want to travel without bankrupting the system? That was kind of what the question was. And believe it or not, it actually made it in the top 30. It ended up 27 or something, but sometimes it's sort of hard to sort that out. And then for sure, older, frail, and First Nations people were underrepresented in this process. Or like they were easily invited, but we did not do a good job of getting them to participate. And just very quickly, we've had trouble getting this paper published. It's now at a nephro journal. We actually started with the New England Journal rather arrogantly, thinking that actually a look at what are the top 10 in our process compared to what's actually researched would be actually interesting to a broad audience. So a nephrology fellow in Calgary did this study. So he basically looked at published literature in the dialysis literature recently, registered trials of RCTs in dialysis currently, and then current studies being funded in dialysis, and looked at what's the topic that they're addressing, and does that match with the top 10? And you can see that around 80% of them actually, only 20% of the currently funded research or current publications in dialysis actually fit the top 10. And there's some things like itching, impact of dietary restriction on clinically important outcomes where there's just virtually no research. So I'm not saying that we've got to totally stop all the research we're doing and only do research that's come out of this process, but I do think this sort of disconnect is pretty striking. And I personally don't think it's appropriate. So just a quick, so I've done this in three other areas. The other sort of serious national one was in kidney cancer. And you'll note that the top 10 here are much more biological. you know, it's on different details around different treatments, and I was blown away. And it's interesting, the characteristics of the patients that come are kind of different. I was blown away by the knowledge of the patients on this one. Like, you know, some clinician would say something about, how about this, and someone would say, well, I was at the meeting in the American Cancer Society, and there's 3 randomized trials of immunotherapy already underway, so I'm not sure that that should be a top priority. Like this woman like knew her stuff, right? And so, but you know, there still were some obviously non-drug ones around psychological emotional support, and interestingly, one on developing decision aids for patients, a health services research one. And this one actually, I've thought about this a lot actually, this was only about 2 weeks ago we had it. I don't think I would actually allow a broad question like this anymore. I mean, doing research in what causes kidney cancer, I mean, it's so broad. I think to me it would be like, are you interested in nutritional factors that cause, it would be like doing research in the treatments of kidney cancer, right? But that's just hindsight. Did one this was just a purely Alberta one on gestational diabetes. So interesting, because here, generally, the women have gestational diabetes, and then once they have their kids, it's no longer a chronic disease, like is the case with, we actually had people with metastatic kidney cancer attend the workshop. And actually, it was hard, really hard, to get women to be on our steering committee, because most of them had kids, and were just so friggin' busy with their lives and looking after their kids, so that was an interesting thing. But there's some of the, again, pretty broad variety of questions. And then finally, actually, a graduate student in Toronto, this was kind of different, was on sort of parents of relatively healthy kids who are raising their kids, like what kind of questions you have about being a parent. And like, you know, my wife and I sort of, like, as long as the kids were polite and not shooting up heroin in the corner, you know, we were pretty happy. And it was interesting to me that, like, a lot of the parents that came to this, like, appear to have read every parenting book ever written, right? But nonetheless, it was a very interesting, so this is basically family docs, nurse practitioners, pediatricians in the community, and parents coming together and saying and it's sort of an interesting mix of questions as well. Yep.
I was just wondering, was there consideration to at which stage in the, I'm going to call it the parenting process they were at?
This was largely, I'm just trying to think, but it was sort of focused on the sort of 1 to 5 years of age sort of thing, yeah. Julia very appropriately sort of challenged me, very politely, she actually didn't say this, but the question really was like, you're doing all this stuff and like, how do you know that makes a difference, big guy? So that's a very, very good question, and actually this is a quote from one of the leading patient, not just patient involvement in research, but sort of patient involvement in healthcare advocates, Simon Denegri in the UK, who says, you know, the evidence base for all this is meager, patchy, and largely observational. That's absolutely true. I do think there's actually almost enough evidence, and you know, when I look at that 80% of research, or 20% of research that's done is, only 20% of research is done is in the priorities of the patients. That's almost in the era of like, you don't need a randomized trial on that one. It's like pretty striking. And it's been reproduced a number of times in other diseases. So the question, of course, actually interestingly, when you submit these papers for publication, sometimes the reviewers say, yeah, so there's a difference, but like we're right. Like who's right? I mean, I would philosophically argue that the patients should have a say, and it's not just the researchers. But actually, a question I get asked a lot is the workshop necessarily? Because it is fairly expensive, right? If you're flying people from across the country, even for a day, and you feed them, and you know, it's like 25 grand before you know it. Now, I personally thought that the interactions really enriched the thing, but actually we're doing a randomized trial with the same nephrologists in Calgary who are doing a similar process for non-dialysis renal failure, and Sharon Strauss. And the participants are going to be randomized to, at the end, having a workshop or doing it on a wiki. And now, that's only a randomized trial and a 1. So, like, is it gonna be that convincing? But at least we're trying. You know, you can also imagine doing a randomized trial and just randomizing people into 2 different workshops and having them going parallel, right? But again, the N is pretty small RCT, but just from a practical point of view, if the wiki gives much the same, and you could do some qualitative research actually, looking at the interactions on the wiki, because that'll be recorded, and also we've recorded some of the small group sessions, and looking at what gets brought up, what's the interaction. By reliable, I mean if you had 2 workshops going on at the same time, would they come up with the same questions? I'm sure they wouldn't. I suspect they'll be similar, but who knows? You know, this is really important. So in Scotland, for research priorities for people with severe stroke, they literally went to small villages where, and you know, the Heart and Stroke Society would have an evening where people with stroke would get together, and actually the JLA went to them. And that's the way they at least sort of engaged them. But I think it's important that this just not become a middle class, so instead of having middle class to upper class researchers setting the priorities as middle class to upper class patients, is probably a bit better, but probably not entirely where you want to go. And that this is sort of similar to my pointing out the quite ill for person on dialysis. And actually I'm kind of interested in the Canadian, to your point about mental health, the Canadian Alzheimer's Society is planning to do one of these on Alzheimer's, but the UK Alzheimer's Society has already done one. And it'll be interesting just to see, and my guess is that, you know, health services questions will probably differ among the countries, but, you know, dialysis people in England are just as itchy as dialysis people in Canada, I suspect. So I think some of the more medical questions, my guess would be, are going to be fairly similar. So my quick segue in the remaining time to healthy debate. So this is a group of people, actually this is Wendy Levinson, the former chair of medicine, so she's not, that's me, and that's Roger Chafe, who's a health technology assessment researcher in Newfoundland, and this is a guy who was a med student at Harvard. But all the rest of the people are people who volunteered to spend, we basically had a company random digit dial people and say, would you be willing to spend 3 weekends a year with these geeks from Toronto, University of Toronto, to deliberate about value-sensitive issues in healthcare? And these people volunteered. And they were pretty, you know, to be honest, actually it's probably the most nervous I've been in like about 10 years. Like I give enough talks that I don't get nervous for talks anymore, and you know, people like David Feeney are kind of intimidating, but I can't be too. But like walking into a room where there's sort of citizens who you've had no say over selecting them whatsoever, and they kind of weren't sure what we were all about, we kind of weren't sure why they volunteered. They were very suspicious about who's paying for this, and then we said the Canadian Institute of Health Research, and then they said, whoa, that's the federal government, like is Stephen Harper paying for this? And it's sort of this hand, no, seriously, like it's